Welcome to the Stat AI podcast.
Welcome to the future of emergency medicine, a realm where artificial intelligence isn't just a buzzword, but a beacon of hope and a tool for transformation. I'm DJ Apakama. My co-host Ethan Abbott and I are both emergency physicians, and we have witnessed firsthand the burgeoning role of AI in our field. Our everyday experience grappling with healthcare disparities and social challenges have led us to a pivotal question. In the wave of AI applications, what changes are coming to emergency medicine, and will they be for the better? This podcast was born not just to ask these critical questions, but to seek out answers from the experts, to understand and to demystify the potential of AI in emergency medicine. We believe in bringing this conversation to the wider community to embrace AI as a tool for positive change. This podcast is our exploration of that future, a journey we invite you to join. So let's embark on this path together to learn, to question, and to envision a new era of emergency medicine enhanced by the power of AI.
Hey, DJ. Welcome back to Stat AI, the podcast dedicated to demystifying artificial intelligence and data science for the emergency medicine community. I'm Dr. Ethan Abbott, alongside with my colleague,
Dr. DJ Apakama and Ethan. On Stat AI, we explore the cutting edge where technology meets emergency care, looking at how data, algorithms, and AI are starting to transform our practice.
And today, DJ, we are tackling a topic that hits right at the heart of everyday emergency medicine, but through the lens that data science is uniquely positioned to illuminate. Picture the scene. It's a Tuesday afternoon. The waiting room is packed, the overhead lights are buzzing, and you've just picked up your third patient in an hour, complaining of, you guessed it, chest pain.
Yeah, it's definitely a scenario we all know well. Chest pain, or maybe something a bit more nebulous, shortness of breath, fatigue, dizziness. They all should set off alarm bells. It's one of the most common reasons people come to the ED. Millions of visits every year in the U.S.
Exactly. Our initial diagnostic approach often feels like muscle memory, doesn't it? I think we get the vital signs, we get IV access, we get an EKG, ideally all within that 10-minute window as mandated by guidelines. Based on the initial assessment, we likely send off cardiac markers, most commonly troponin. These are the foundational steps that we all take in the ED.
These are the bedrock of our evaluation for potentially life-threatening conditions, just like ACS, acute coronary syndrome. We rely on these tests to guide our immediate management, our risk stratification, and our disposition decisions. It feels objective, standardized, or at least we strive for it to be evidence-based.
But I think there's a really uncomfortable question we need to grapple with today, which is how objective is the initial workup? When you're juggling multiple patients under pressure, making rapid-fire decisions, could factors beyond the clinical presentation be subtly influencing who gets which tests and how quickly? Factors like a patient's race, ethnicity, their sex, maybe even the primary language they speak.
That's definitely a crucial question, Ethan, and one that makes many of us pause. As emergency clinicians, equitable care, providing the same exact high standard of evaluation to every single person who walks through our doors, is absolutely fundamental, and I would say it's part of what makes us emergency physicians. But we also have to acknowledge the reality of implicit bias. So there's been decades of research, including in cardiovascular care, which has shown that disparities exist. Are these biases influencing even these initial, seemingly straightforward diagnostic steps?
And that's precisely what a major study that we're going to talk about today was published recently in the American Journal of Emergency Medicine aimed to find out. The title is Disparities in Troponin and ECG Testing Among Emergency Department Patients with Chest Pain. The way they conducted the study is really significant and I think relevant to this podcast in itself, particularly the data set that they use. It really speaks, I think, to the evolving landscape of health data research.
Ethan, this wasn't a small single center study, which has been a limitation of a lot of past research in this area. The authors leveraged the Epic Cosmos research platform. This is a prime example of large-scale EHR data collaboratives that are becoming increasingly influential and hopefully more common. Cosmos aggregates de-identified EHR data from hundreds of healthcare organizations across the U.S. that all use Epic systems. At the time of this study, we're talking data from nearly 300 million patients and about 1,600 hospitals.
That scale is really staggering for this type of research. It represents an immense power shift in our ability to conduct research. We can move beyond the limitations of single center studies or smaller networks and start looking at real world evidence reflecting national trends, diverse populations, and varied practice settings, all based on data generated during routine emergency department care. It's a potential goldmine for epidemiological health services research and understanding treatment patterns, and potentially training and validating AI models on these massive data sets.
Exactly. The potential is huge for accelerating discovery, but we always need to consider with these large databases, we have to be mindful of their inherent characteristics and limitations. While Cosmos is vast and designed to be representative, it's not a complete picture of all U.S. healthcare. It only includes data from institutions using Epic's EHR and who voluntarily choose to contribute their data. So there's always a potential for a major selection bias here. Are the patients and practices within the Cosmos network systematically different from those outside?
That's a really critical point. And the data itself is only as good as the documentation in the electronic health record. We're reliant on how symptoms were recorded, how race, ethnicity, language, or self-identity was documented. And there's always a risk of misclassification or incomplete data, the classic idea of garbage in, garbage out problem, especially when dealing with automated data extraction from records that were not initially designed for research.
The old GIGO problem. And the de-identification process, while absolutely essential for protecting patients' privacy and ensuring HIPAA compliance, also introduces another constraint. So, for instance, the study notes that to maintain compliance, Cosmos suppresses counts where there are fewer than 10 patients in a specific subgroup. While this only affected 1.26% of cases that were imputed as zero, it highlights how privacy measures can limit granular analyses of rare events or very specific populations. It also restricts linking EHR data to external data sets, like mortality registries or socioeconomic data, which could have even provided richer context.
So we have this incredibly powerful tool in Cosmos enabling studies of unprecedented scale, but we need to interpret findings with these caveats in mind: potential selection bias, reliance on EHR data quality, and the limitations imposed by de-identification. It's a trade-off we often make in large-scale observational research.
Yeah, it absolutely is. And understanding the data source is key to understanding the studies. Acknowledging both the power and the limitations of using the Cosmos platform, let's go ahead and dive into what the research actually found when they analyzed those nearly 37 million ED encounters for chest pain and anginal equivalents over 8 years using this specific data set. What did this large-scale, real-world data reveal about ECG and troponin testing?
I think most importantly, the results confirm that significant disparities persist and exist. Let's start with sex. Consistent with some older studies, they found that female patients were significantly less likely to receive both ECG testing and troponins compared to male patients presenting with similar symptoms. For troponin testing, for example, the odds ratio for males was 1.087, meaning males had nearly 9% higher odds of getting a troponin test done than females, even after controlling for age and year.
So almost a 9% difference in odds for a test as critical as troponin, just based on sex identified within this massive data set. That's kind of sobering. What about race and ethnicity?
Similar patterns emerged and again were particularly noticeable for troponin testing. For ECGs, for example, they found that patients who self-identified as Black or African American had lower odds of receiving an ECG compared to white patients. The odds ratio here was 0.955, representing about a 4.5% lower likelihood. Patients identifying as other race also had lower ECG rates.
Yeah, so the signal for ECG disparities is still present in large cohorts, particularly for Black patients and for women.
Correct, but the disparities were even more widespread. The study found that all non-white racial groups analyzed, including American Indian or Alaska Native, Asian patients, Black or African American patients, Native Hawaiian or other Pacific Islander and other race patients, had significantly lower odds of receiving a troponin test compared to white patients. The odds ratio ranged from about 0.918 to 0.950, meaning these groups had anywhere between 5 to over 8% lower odds of getting a troponin test ordered by the physician or provider.
So across the board, Non-white patients were less likely to get this cardiac biomarker checked, according to this Cosmos data. Additionally, patients of Hispanic or Latino ethnicity also had lower odds of troponin testing, about 8% lower compared to non-Hispanic or Latino patients.
It's a striking pattern revealed by this large-scale analysis, and the authors make a crucial point. While some of these odds ratios may seem numerically small when you apply them to the sheer volume of ED visits for chest pain, potentially 11 million patients, these small percentage differences translate into hundreds of thousands of individuals potentially experiencing delays or omissions in their cardiac evaluation based on their demographic background.
Yeah, that really underscores the public health significance here. It's made visible by the scale of the Cosmos dataset. It also highlights the difference compared to some older studies where ECG disparities were perhaps more prominent. The authors speculate, and it makes intuitive sense, that with the widespread push for rapid door-to-ECG times might have somewhat standardized ECG ordering, potentially reducing the space for bias to operate compared to troponin testing, which can be less rigidly protocolized.
I think that's a plausible explanation, but let's pivot to another intriguing finding from this data set, which is language. What happened with those patients whose primary language wasn't English?
The study found that patients who primarily spoke Spanish had slightly higher odds of getting both ECGs. The OR was 1.039. Troponin, odds ratio of 1.016 compared to English speakers. For patients speaking other non-English languages, the difference was even larger, about 5% higher odds for ECGs, OR of 1.054, and over 6% higher odds for troponin, an odds ratio of 1.064.
So non-English speakers, particularly those speaking languages other than Spanish, were more likely to get tested in this cohort. What do the authors suggest might be going on here based on this data?
What they saw, which could represent over-testing driven by communication challenges. So clinicians ordering more tests to compensate for their uncertainty. Cultural differences in symptom descriptions might also play a role. So the larger effect for non-Spanish languages might relate to interpreter availability differences, but they stress this needs more investigation. Does this higher testing rate translate to better, worse, or equivalent outcomes? The Cosmos data used here doesn't tell us that.
It's a fascinating wrinkle revealed by the granularity of the data, but the overarching theme remains, which is this large-scale, nationally representative study enabled by a platform like EP13 demonstrates that significant demographic-based disparities in fundamental cardiac testing persist. So, DJ, this brings us back to the crucial stat AI part of the discussion. We have this powerful data analysis tool for identifying a major problem. What do we do about it? And how does the nature of the data source like Cosmos influence how we approach solutions, including AI?
The strategies propose education on implicit bias, standardized protocols. The existence of platforms like Cosmos adds another layer. The ability to monitor these patients across vast populations in near real time is unprecedented. Institutions within the network could potentially track their own performance against benchmarks derived from this aggregated data.
And for AI development, having access to such diverse data sets is crucial for training robust models, but also means AI models trained on this data could inadvertently learn and even perpetuate the very biases observed, if not developed and validated extremely carefully. If the input data reflects lower testing rates for certain groups, an AI tool might learn that pattern as, quote, normal, unless specifically designed to counteract it.
Right, and that's the double-edged sword. Right? It really is the whole crux of it. The data reveals the problem, but it could also bake the problem into future solutions if we're not vigilant. So it really underscores the need for fairness-aware AI development and continuous auditing algorithms deployed in these clinical settings. Studies like this one using platforms like Cosmos are, I think, vital first steps, and they hold up a mirror to our current practices.
Exactly. It's about using data not just for discovery, but for driving improvement and equity while being acutely aware of the data's origins as well as its limitations. This study didn't evaluate interventions, but it lays the groundwork for clearly defining the problem on a national scale thanks to the power of aggregated EHR data.
It's really such a critical conversation about ensuring equitable care for one of our most common and high-stakes presentations, informed by the capabilities and caveats of modern health data infrastructure. So stay with us as we dissect data and discuss the future of emergency medicine and AI in future Stat AI segments here.
And thanks so much for tuning in. This is part 2 of our discussion with Shivam Vedak and Dong Yao from Stanford University. We hope you enjoy this episode. I think the next question we wanted to talk about is looking at AI in the documentation sphere, which might put some listeners to sleep, but I do think it's an important potential task for this technology. We've seen studies where AI-generated documentation saves lives, but others where it can add this extra review burden. In your experience, do you think AI can actually make charting and documentation easier for physicians?
So this is an interesting question. I think from what we've seen both internally in our studies and our analysis of users and from papers is that it's really phenotype dependent, meaning it really depends on the user and how they think and how they approach documentation. If you are internal medicine like me and you really perseverate over your notes and care about the look, you may not get as much mileage out of it because the AI is unlikely to be perfect. And that is challenging for some people who are perfectionists with their notes. If you are the type of person that thinks of documentation as something that needs to be done and it's an output as long as it captures everything that you discussed is okay, and you click enter, then you're probably going to benefit a lot more from it. And I think as ambient dictation rolls out, people are actually starting to move a little bit more from the former of being perfectionist to the latter, because you can either have a perfect note or you can be home in time to have dinner with your kids. And I think people are starting to shift towards that.
Yeah, that's a good point. We're still in the first wave of ambient dictation and AI documentation, and the jury's still out in terms of whether or not it helps. That said, I think there is almost no reality in which it will not eventually help and help in a significant way. It's just going to take us a little bit of time to get there. And I think the big fundamental issue that we're facing right now is not necessarily one of proficiency, but really of trust, right? What you mentioned about there being an added review layer is exactly what we are seeing. The AI does things and then you have to manually review it, right? Think about if you are an attending physician at an academic center, like what a good resident is, right? Or a trustworthy resident. If you ask them to do something in a critical situation, they will do it almost all the time and they will do it well and they will report back to you. If you mirror that on an AI model, you can't have an AI who works well 90% of the time. And then 10% of the time, they just forget to order that life-saving medication you dictated in the room. There's problems about interpretability, about transparency. But as this underlying technology gets better and the error becomes less and less, we're going to get to a point where we start to trust it to the level of, well, everyone makes small mistakes here or there. And occasionally they might miss things, but like 95, 99% of the time, it's good enough for me to just very quickly scan and accept as the truth.
The important thing to remember about these types of studies is that this technology is the worst it's ever going to be. And it's constantly improving. However, those studies that make the headlines and get accepted by journals are really the first comers. You're not going to see those incremental improvements that are seen in the world, but not in the literature.
Wow, it's a great point. Are you saying we shouldn't be looking to New England Journal and JAMA constantly? It does bring up the point that I actually want to ask, which is if the AI gets so good that 99% of the time it's telling you the truth, how are we teaching people to critically evaluate that 1% of outputs where the AI is leading us astray? How do we co-teach those skills so that one doesn't become such an issue?
Boy, that's a really hard question. I think this is going to be a fundamental problem that we need to address in the education space moving forward. And this doesn't just apply to medicine, it applies to all education. Like the kids right now are growing up starting to learn Python, and this is not stuff that we learned growing up. I believe that in a few years, and probably honestly now, this is going to be education that starts to get incorporated longitudinally to education. It's relevant in all aspects of our life now, right? I would hope that part of it incorporates some version of basic education about, hey, this is how hallucinations happen. Hey, this is how you do critical thinking. You should be aware of automation bias. You should be able to catch things that don't make sense. It's to give more specific advice than that.
Automation bias is real. And the first step to addressing it is having everyone recognize it and self-reflect when you're using it. The other thing is having external tools to help more critically evaluate at systems level. So we've started implementing here with our automated draft response technology, some preliminary ways of checking for automation bias. Are people actually making edits to these drafts that are going out to patients? Are they not? Or over time, are people making less edits? And hoping to catch those issues with automation bias ahead of time. But I think also a lot of it comes down to what sort of model are you using? Again, going back to factual tasks, tasks that involve retrieving answers that must be factually accurate. I think you should try to rely on models that use a RAG-based approach or source their answers, and then also try to look at the sources. Because while it may have grounded in a truth, it may have misinterpreted what that documentation is as well. So I think part of it is for very critical tasks, like if you're writing a manuscript, you should not just blindly trust these LLMs. You should definitely go follow the sources and make sure that it is factual and accurate. For lower tasks, like for example, if you're just asking, what is the best way to get the stain out of my shirt? Maybe you can not have to do this whole chain of trying to figure out, is this factually accurate or not?
Yeah, and actually, I think Shivam brings up a great point in regards to healthcare. There should be quality controls and monitoring in place to assess evidence of automation bias, and there's different ways of doing that, right? Think about our clinical decision support and best practice alerts. We're able to see on the back end how many times people click on certain buttons, how many times they reject it and accept it, and that sort of conveys some hidden layer of meaning. We can do the same thing for AI automation. If the health system starts to realize that literally everyone hits auto accept on a draft message in 2 seconds without reading it, that's telling us something about our mindset and technology. People above our pay grades will have to think, what should we do with this? But self-awareness and systems level awareness of these kinds of biases are very important.
Yeah, totally agree. I think this next question is also challenging, but dovetails quite nicely in this area. We know that the models can inherit biases from their training data. Have you encountered any instances where you see sort of bias in an AI tool directly affected a clinical decision or workflow? And if you have, how do you propose solutions, or how should hospital systems be approaching this problem down the line?
So I personally don't think I've seen an example directly that I can quote right now. That doesn't mean it doesn't exist. I'm 100% sure it exists everywhere. I think the one example that I've heard of, not at Stanford, but in general, is a case study that was published. They had a no-show prediction tool, and we're using that to help schedule patients in the clinic. Essentially, what they found out is that certain patients, particularly those of a lower socioeconomic background, tended to no-show more, and then they essentially didn't let them schedule appointments, and it caused a huge shift in care, and it exacerbated issues and disparities. One of the ways that we were taught to think about this, and we're very fortunate to have one of the thought leaders teach us these things, Nick Shaw at Stanford. The way he thinks about it is essentially there's bias, but then it's really, is this causing harm? Is impacted by how you're impacting it, you're integrating it in your workflow. If you have a separate step that helps mitigate that harm, and you have a physician or a human in the loop, that will reduce the amount of harm that bias causes versus having just an automated tool like a scheduling tool that actually caused harm because of the way it was implemented.
Yeah, that's a great example. I have to agree with Shivam here. I don't think I have a great personal example, but that's also probably because we are not yet at the place where these systems are deeply integrated into the care yet. We're flirting with small projects and things of that nature. I actually think there's maybe two different areas, right? So there's LLM bias, which I almost think potentially could be easier to address, right? There's studies out there that show that if you give an LLM a name of a certain ethnic background or a certain gender, it assumes certain roles, certain jobs about you, which is obviously biased. But in some ways, those are easier to catch. I think the more insidious problem is something that we haven't talked about too much on this podcast, which is machine learning and deep learning and true black box sort of math models, where it just spits out a result and there's really no way to interpret. It just says, this person is going to die in 17 days, some like Minority Report level thing. And it's going to be really hard to tackle. And I think using a structured framework, if you're an institution, is probably the best approach right now. Stanford uses its own structured framework called FIRM. As literature gets published about this is what everyone's going to be paying attention to, which is like, what are the established ways of doing this in a rigorous and scientific manner? What are the right committees to be having? What are the right kind of questions to be asking? And also evaluating things like model drift over time. This is a moving target for sure.
Yeah. I've encountered that firm before. Can you just spell out what the actual steps are?
Yeah, so FIRM stands for fair, useful, and reliable models.
Essentially, it's just evaluating them on those domains. The data science committee, before we implement an AI tool, have the discussion. Is this tool fair, useful, and reliable? We have multifaceted experts in various domains, the business case, the physician case, the computer scientist, data scientist case. And you have almost like this roundtable discussion about these models before they get implemented to make sure that we're being thoughtful about the implementation. And then afterwards, there's ongoing monitoring to make sure that A, there's no drift, and B, that we were correct in our initial assumptions and that there aren't other things that we need to reconsider now that we've actually deployed this tool.
Yeah, it's essentially a structured report card that looks at all domains, including business and ROI. Those are important questions we ask them too.
Right. And so for our listeners, that's FIRM, FURM, fair, useful, reliable AI models. Switching gears slightly, I wanted to ask you, we've been a little down on AI here, I feel like. I want to bring back the excitement. What do you think currently in medicine, AI-wise, everyone is excited about, but maybe not ready for prime time? And where should we be looking for the real hype?
So I think one of the tools we're going to be seeing rolling out in 2025 that I don't necessarily think is ready for prime time is summarization. Summarization is an incredibly complex and difficult task. I spent a lot of my operational work with our Stanford Emerging Applications Lab working on summarization integration. It's difficult and not ready for prime time for a couple of reasons. One is summaries. Think about when you ask a medical student, a third-year medical student, to summarize a patient or present a patient. A lot of times they get it wrong in the first try because they don't know what's useful, what you want to hear. And a lot of that comes down to summarization is not global. It's specific to tasks and people. If you're an infectious disease physician, you want to hear something different than if you are a cardiothoracic surgeon. It also depends on what the patient's coming in for. You don't want to hear a bunch about their diabetic history if they're coming in for appendicitis. So again, it's specific to the physician or the end user, the reason the patient is presenting. Finally, we have a massive information problem in healthcare. There's way too much chart data, and we've seen that LLMs, when you increase the context window, can theoretically accommodate 2 million tokens. But recent study that came out even just 2 weeks ago says that while it's good at finding a specific phrase in the chart, it's clearly good at that over that whole 2 million tokens. But when you take 1 or 2 levels of abstraction away from that, it does really bad at reasoning. So for example, you have a patient in the chart, it says they had a white blood cell count of 20. A needle in the haystack example of that would be just finding that WC is 20. A first level abstraction will be that white blood cell count is elevated compared to the reference range. Second level abstraction will be that this person potentially has an infection because the white blood cell count is elevated. Those levels of abstraction get really challenging as you increase the window or the amount of information or tokens you feed an LLM due to the way it works. The attentional complexity increases quadratically based off of the math behind it. Each token has to look at every other token in the context as you increase the amount of tokens in your context window. A lot of the information in the chart, and I feel like that's not talked about enough, is often just wrong. When you have really complex patients, people have issues with summarizing things accurately. And because of that, I think LLMs aren't necessarily able to judge what information is correct and what is not. And because of all of those things, I think summarization is just a really hard task.
Shivam stole the words right out of my mouth. I also wanted to say that. And I think the reason I want to say that is because I really want this to work and I know it will work, but this is probably one of the things that will make the most difference for me as an emergency physician, right? Like, here are 5 critically sick patients you've never met before who's not even registered in the healthcare system. Go take care of them, right? It's kind of impossible. Well, it's not impossible. We train for it, but it would be so nice and have a little robot whisper in my ear everything that I need to know in a condensed way about those patients. I think access to healthcare is a promise that is being made, but has not happened yet. I think AI has decreased to some extent the information asymmetry. Any patient can now go look up what nephrocalcinosis means or what are the warning signs if they so cared. I don't think there's been a significant amount of new appointments that have been made, right? Not more doctors have been trained. And I think even more importantly, there's this promise that in the future, there's going to be workflows that can replace a lot of the non-clinical but highly important workers in healthcare. Maybe not replace, but augment. Social worker, nutrition counseling, diabetic health coaching. I can think of several healthcare companies out there that are starting to make these promises, but I think time will tell if those things actually pan out.
That's great. I think as we round out towards the end of our conversation, we wanted to look at the future of AI. We talked about AI developments in medicine. One of the questions we touched on, which is critical moving forward, is medical training. How do we think about redesigning medical training to work in tandem with AI and technology? You both come from different specialties, so your answers might be slightly different given emergency medicine and internal medicine have somewhat different training structures. Shivam, maybe I'll start with you. How do we think about redesigning curriculums and how these tools can work together for clinical decision-making and all the other aspects we talked about?
Yeah, this is a really funny and topical question because we just had a meeting yesterday about this. And how can we integrate prompt engineering or our version of the talk into the curriculum in a way that won't bore students, but also it recognizes the need for this in their curriculum? I think one way is really emphasizing the use of the AI as a tool, recognizing that this is a way that you can augment your care, and having medical students practice with it when being patients. And rather than having them just try to figure it out on their own when they're on the wards or as residents. So I think really just integrating it as a co-pilot, as something that it will be part of your future and incorporating it into daily decision making.
I think for me, maybe two general ideas come to mind. Number one, we need to be teaching clinicians how can this technology augment your daily tasks, right? How can you, even beyond using LLMs, like other things like deep learning models, what are the ways in which these things can help your tasks, help your daily life and not replace you? And I think number two, more importantly, you mentioned practice. I think that needs to be in bold, right? This is a hands-on practical skill that requires a lot of reps to get right. What might practice look like? I'm not necessarily saying you need to practice prompt engineering. Perhaps it is some intermittent education about having, like asking an LLM a question and been given a multiple choice answer of, like, let's say 5 different answers, and then be able to identify which one is at the highest risk for bias or which one should be concerning. It may also be things like, given this patient vignette, what are the different ways in small group that we can practice getting the most learning out of this case? Or potentially, what are ways that can help increase our diagnostic proficiency? I think practice is going to be really important.
All right. And I think that brings me to our last question. We'll round off the show with this one. If you could give just one piece of advice to a clinician who's curious about AI but hasn't started using AI, what would it be? No reps, okay?
I don't overthink it. As physicians, we have this tendency before we dive into something that we want to look at everything, learn everything about it, especially in internal medicine. I think you guys are a little bit more daring in emergency medicine. Try to get all the information you know about something before you try to use the tool. Rather than that, just think about it as like this brain dump tool. As both of us, DJ, you and I, as we progress in using this tool, have gone from this structured way and this frameworks and everything to just this brain dump. I'm going to microphone dictate into this and it'll give me a good answer. And I think people should approach it and not get caught up in being perfectionist with their interactions with AI.
I would offer reassurance and encouragement. Even the term prompt engineering has a scary word engineering in it for those of us who are not engineering background. But there truly is not much preventing you as a normal, curious clinician from being proficient, from being an expert, and in the top 5% of users, efficient users, compared to someone who has a hard data science, quantitative CS background. These are low code, no code tools. Fundamentally, it is about the approach to the problem. It is about how you can clearly communicate. Every single day, I talk to patients who know nothing about the topic that, I'm talking to them about, and I have to break down incredibly complex ideas into smaller bite-sized pieces that people of all different levels of understanding can understand. That's exactly what using AI is, at least in 2025. You are already an expert in this. You just have to keep practicing.
I love that. That's great. Thank you guys so much. I feel like you bring so much of not only your own expertise, but practical knowledge. You're trying to put this to use in situations that mirror what our listeners are going through. So we thank you so much for coming and sharing your viewpoints on all of this.
Thank you both for joining us. That was an absolutely incredible conversation, and your insights will resonate with all of our listeners. Thank you so much.
Thank you for having us. We've been big fans of the pod, so we're happy and excited to be on here.
Looking forward to continuing the conversation. See you guys soon. Thank you so much.
Thanks so much for listening to episode 13 of the Stat AI podcast. If you get a chance, check us out on X and Instagram and our newly updated website, stataipodcast.com. And make sure to tune in next month for some more amazing content. Thanks so much and take care.
Please note that the views, opinions, and information expressed in this podcast are solely those of the individual speakers and do not necessarily represent those of their employers, our sponsors, or any affiliated organizations. The content provided is for informational and educational purposes and is not intended as medical advice. We encourage you to consult with qualified healthcare professionals for any medical concerns or treatment decisions. This podcast is not a substitute for professional medical advice, diagnosis, or treatment. Listener discretion is advised.